I am an active pediatrician from Professor Senaka Bibile Memorial Hospital. So I'm Dr. Dimuthu. I think these most of the trainees know me. So there are several these my HOs as well as these during my these register period there are some HOs as well as some colleagues were there. So I would like to start my presentation because this is a very interesting. There are several cases here. So I am working as an acting consultant pediatrician since 2017. So I have start my works at base hospital Simalandu for 2 years, then moved to this base hospital Akrepattu, then this general hospital Lampara. Now I am working at this Professor Senaka Bibile Memorial Hospital for last 9 months. So during this period, that's means since 2017, I have worked at this peripheral pediatric unit, mainly in this Ua province and this eastern province. So during that period, I have diagnosed several new cases. Some of these cases are very rare cases. I think most of you have not seen these type of cases during your life. Because I am also sometimes I was also seeing these cases first time in my life during my career. So there are several cases I will discuss here because these things are very important. This is your registrar period. This is your beginning of your career. So if you have interest regarding these uncommon cases, uncommon diseases, so if you have interest, you can diagnose. You have to always see these cases because if you have interest regarding any pediatric child, always think about this child has some abnormality. So if you look like that, so you will diagnose these uncommon cases. Otherwise, if you think simply these things are very normal, there are no problem at all in this child, so you will never diagnose any uncommon cases. So if you want to diagnose these uncommon cases, you should always think this child has some abnormality. So that's the first thing you have to learn during your this registrar period. So I have worked for several years during my registrar period with several very good consultants during my period as well as this SR period also. So during that period, my teachers always taught regarding these things. So firstly, I would like to emphasize that. So then, so during these 5 years period, so I have worked in these places. So during these working places, I have diagnosed these cases. So firstly, I would like to mention regarding these uncommon syndromes. So these syndromes are, some syndromes are very rare. Some syndromes you can found during your this registrar period, but some syndromes are very rare. So first syndrome, sickle syndrome. So second one is Dobie syndrome. So third one is chromosome P deletion syndrome. Then Grisel syndrome, Mermaid syndrome, golden hair syndrome, and Beckwith-Trademark syndrome. These are the main uncommon syndromes I have diagnosed during last 5 years. So some of these cases I have published in our annual sessions. So Dobiewicz's 5p deletion, Grisel. So I have Sickle syndrome. So 4 out of 7 I have published in this our annual session in last year. So these are the very rare syndromes. So we will discuss regarding these syndromes. So then Second part is uncommon pediatric diseases. So some of these diseases I have seen first time in my life. So if you have interest, you can diagnose any type of rare disease or any type of rare syndrome. If you can think about these diseases. So first one is Kawasaki disease concomitant with primary Epstein-Barr virus infection. Second one is Rhizomelic chondrodysplasia punctata. This one I have seen in first time. So Kawasaki disease with concomitant primary Epstein-Barr virus also first time. And Phacomatosis pigmento vascularis, that's also first time in my life. And Neuroblastoma presented with proptosis and Neurofibrosarcoma of the lumbar spine. And other one is Rosay-Dorfman disease. This is also first time in my life I have seen. And cardiomyopathy with congenital cytomegalovirus infection, calcified posterior mediastinum neurogenic tumor, and autosomal dominant congenital nystagmus syndrome. This one also I have seen first time. So out of these 9 cases, so these 8 out of these 9 cases I have published in these annual sessions. So last year as well as this year. This year I have published this autosomal dominant congenital nystagmus syndrome, calcified posterior mediastinal neurogenic tumor, cardiomyopathy congenital cytomegalovirus infection, Rosay-Dorfman disease, neurofibrosarcoma, neuroblastoma presenting proptosis. So those 6 cases, this annual session I have published. So other 2, Phacomatosis pigmento vascularis and rhizomelic chondrodysplasia last time I have published. So during your registrar career, always think about this uncommon disease, not only common disease. So if you think about this uncommon disease, you will diagnose these children. Otherwise, you will miss. So then I will move to this each case separately. Sickle syndrome. So I think a lot of people have seen the Sickle syndrome. I have seen nearly 5 or 6 cases of Sickle syndrome. So this is a rare autosomal disorder. So marked uterine growth retardation is there. In addition to that, microcephaly, cataract, clinodactyly, hip dislocation, and cryptorchidism is there. So in addition to that, they can have mental retardation, severe growth failure. So this developed during this intrauterine life. That's why we call this marked intrauterine growth retardation is there. In addition to that, they can have a severe childhood as well as adult growth failure. The most prominent feature in this syndrome is they can have this big nose with micrognathia and low-set malformias. In addition to that, they can have congenital heart disease, and they have this more risk to develop this osteosarcoma and hypoplastic anemia. So that's the main features of this Sickle syndrome. So I have diagnosed 2 siblings in same family with this Sickle syndrome. This elder one is around 10 years. So you can see the size. This other younger one is 4 years. You can see the size. They are very, very small. So mainly due to this intrauterine growth retardation. So this case I have published in last year in our annual sessions. So this is a case report. You can see that 2 siblings of Sickle syndrome in a family. So this is a very rare genetic disorder. So this actually I first diagnosed this 5-year-old boy, 5-month-old boy. At that time, child was 5 months old. So then with this history, so then I bought this elder sister. So she also has same features. So this 5-month-old boy who born to second-degree consanguineous parents with birth weight of 900 grams at 35 weeks of gestation. So you can see there is a marked intrauterine growth retardation. and all other features were there. And here discussion most important thing is Seckel syndrome is an autosomal recessive congenital disorder which is characterized by marked intrauterine growth retardation that continues even after birth, resulting in a short stature. They can have moderate to severe mental retardation which may also be present at birth. Some children with Seckel syndrome may also have associated with blood disorder. So they can have osteosarcoma and the hematological malignancy. That's the first case. So then I will move to this Dobie syndrome. So Dobie syndrome also very, very rare syndrome. So this is also autosomal recessive disorder. They can have mental retardation, hyperactivity, sinus, speech delay, and microcephaly, broad nose, nasal beach, small paces, and micrognathia, eczema. This eczema is very important. That's one of the characteristic feature of this syndrome. And dental caries is other important feature. And the most important feature is syndactyly of second and third toes, and as well as they can have the fingers also, second and third fingers. And cryptophytism, recurrent respiratory tract infection is the other main feature. They also can have malignancies like neuroblastoma, lymphoma, and acute lymphoblastic leukemia. So this is my child. So I have diagnosed this one when I was at base hospital Akrepattu. So you can see these characteristic facial features and several dental caries. And you can see these third and fourth finger. There is these indactyl parts, and these second and third toes between. You can see this indactyl part. Okay. This is a case history I published in last year. So child with Dobie syndrome with recurrent lower respiratory tract infection. So here, most important thing is they can have dwarfism, eczema, peculiar species. So Dobie syndrome is a genetic mutation. This is autosomal recessive. Very few cases reported. Syndrome can cause leukemia, lymphoma, sarcoma, and neuroblastoma. So it will affect these children intellectual development. So they can have this recurrent respiratory tract infection. Actually, this child also presented to me with recurrent lower respiratory tract infection. So then I noticed there are some these subtle dysmorphism, and then I checked this child, and then I found these all the features. If I have not seen this dysmorphism or subtle dysmorphism, if I have not concern regarding these features, I will never ever diagnose this case. So then, third case, chromosome 5p deletion syndrome. So these children, they can have subtle dysmorphism, such as epicanthic fold, downward slanting eyes, low set ears, simian cases, short neck, clinodactyly, flat feet. So in addition to that, they can have microcephaly. Another most important thing is they can have cat-like cry. So their growth also very slow. They can have hypertonia and mental retardation, hypertelorism. So those features were there. So this child also I have diagnosed when I was at this Akrepattu base hospital. So this child came with very subtle dysmorphism. So some features of Down syndromes were there, like Down child. So trisomy 21 child. So I think there is some problem here. So I check these all the features, and then I send these child's genetic blood for genetic testing. That's mean karyotyping. So ultimately diagnose this 5p deletion syndrome. So this one has some dysmorphism. You can see with this picture. This is a genetic report. You can see this 45X5 deletion 5p position. So these are That's case history. So I have published in last year. So case of chromosome 5e deletion syndrome with subtle dysmorphism. You can see this all the features here. Then Grisel syndrome. So this is also very rare syndrome. So I have seen only 3 cases up to now. So including this one. So this this case is very rare case. So these children, they can have, there are 3 types of Grisel syndrome. So the type 2 is the most common type. So they can have brownish eyes, light silvery gray hair. This is also autosomal recessive. They can have recurrent infections and associated with hypertonia, HLH, spasticity, seizures, psychomotor retardation, several petechial rashes, and hepatosplenomegaly. So in my case, in addition to that, diagnosed with genetic assessment, and they can have pancytopenia, hyperfibrinogenemia, high triglyceride level, low protein, and high ALT and AST. And most important thing is they, in blood picture, they don't have these giant cytoplasmic granules in leukocytes. In addition to that, most specific feature is when you get these child's hair shaft, you can see these under microscope. So you can see large clumps of melanocytes pigment in hair shaft. No, there is no continuous this melanocyte pigmentation there. Only cluster you can see in this hair shaft. So in my case, this child, actually this is a case history I published in last year. This is a 13-year-old girl. So presented to me with these recurrent infections and these clinical features. So you can see these gray silvery hair, this eye, this brownish eyes were there, and gray silvery hair you can see. And this child has had these recurrent infections, respiratory tract infection. So then, in addition to that, this child has had these focal convulsion also previously. Child has taken some these anti-epileptic drugs. In addition to that, had recurrent respiratory tract infection. So these, with these features, I has had this some suspicion regarding this, whether it is a cardiac Higashi or is a Grisel syndrome. So then what I have done is, so I get some opinion from our dermatologist. So then she said, can be a cardiac Higashi, can be some albinism, partial albinism like things. So it can be Grisel. So then we discuss and we look at this child's hair under microscope. So diagnosed was Grisel syndrome. So obvious features were there. In addition to that, this child has had this anemia and low platelet count also. So then we have done these other investigations to see whether there is any hematological malignancies, but those things were not there. So then we have given these influenza and pneumococcal vaccination also, because this child has had past history of recurrent lower respiratory tract infection. So this is a very rare case. So always you have to think about these things. So then this is a mermaid syndrome. This is also first time in my life I have seen when I was that Grisel syndrome when I was at this Ampara DGH. So this mermaid syndrome when I was at Akrepattu Base Hospital. So mermaid syndrome also known as this sirenomelia. So extremely rare congenital disorder. In here, so you can see this mermaid. Fusion of lower limbs were there. Both limbs are fused. So in addition to that, they can have lumbosacral vertebral problems, genital problems, or sometimes there is no genitalia. So gastrointestinal problem, that means anus is not there. And in addition to that, they can have renal agenesis and flat face and other features. So this is my child. So when I was at Cardiomyopathy Hospital, we have diagnosed this one, Mermaid syndrome. You can see both lower limbs are fused together. Then this is the same child. So that case I have written to this annual session, but they have not accepted that case. So then golden heart syndrome. I think most of you have seen this golden heart syndrome children several times. I have seen, I think, around five. This is also very rare congenital disorder. This golden heart child was there at this Cardiomyopathy hospital when I was there. So very rare congenital disorder known as oculo-auricular vertebral spectrum and results from maldevelopment of first two branchial arches. So incomplete development of ears, nose, soft palate, lips, and mandibles were there. There is a classical triad here. So this triad is, first one is there is a facial asymmetry due to mandibular hyperplasia. Second feature is ear and OI malformations were there and vertebral anomalies were there. So in addition to that, they have microtia, p-auricular tag or pit, middle ear anomalies, malfunction of the soft palates, hemivertebra. The other most important thing is epibulbar dermoid. So this epibulbar dermoid is very, very important. Sometimes you can misdiagnose this golden heart syndrome with this other one is Treacher-Collins syndrome. So both are like same, but main this epibulbar dermoid is only in this golden heart syndrome. So cleft lip capillary is there, kidney problems were there, heart problems were there. Actually these features are not my child. So these things I download from this internet. So this is a child with golden heart syndrome. So you can see that. You can see here there is a epibulbar dermoid. The ear abnormalities were there. These mouth abnormalities were there. Previous one also same. So ear abnormalities were there. Here the tag is there. This mouth abnormalities were there. You can see here obvious earlobe abnormality. So then I will move to this Beckwith-Weidmann syndrome. So I think most of the people have seen this Beckwith-Weidmann syndrome. This one is somewhat common. So this is autosomal dominant syndrome. They can have macrosomia. So these neonates are very, very large. The children are very, very large. They can have macroglossia, prominent eyes, infraorbital hypoplasia, linear fissure in external earlobes. So this horizontal linear fissures you can see in the external earlobes. That's the most important other features in this Beckwith-Weidmann syndrome. In addition to that, they can have neonatal polycythemia, hypoglycemia. The most of the children presented with this asymptomatic hypoglycemia during neonatal period in Beckwith-Weidmann syndrome. Other features are umbilical anomalies, cryptorchidism, mild microcephaly, hemihypertrophy, uterine anomalies, omphalocele, and childhood tumors. So those are the other features. So this is a child with this Beckwith-Weidmann syndrome. You can see in this large tongue, prominent eyes. So you can see that. So in addition to that, you can see here there are these linear horizontal fissures in external earlobes, large tongue. So those are the main features. So those are the main common syndromes. So all those common syndromes, not common actually, uncommon syndromes, I have diagnosed during last 3 years in these 4 hospitals. So if you have interest, always you can diagnose any type of uncommon syndrome if you have interest. So then I will move to these other uncommon diseases. The first one is Kawasaki disease with concomitant Epstein-Barr virus infection. So you know regarding this Kawasaki disease as well as the Epstein-Barr virus infection. Here, this both diseases together in one child. So this is very, very rare. So this case also I have written to these our annual sessions, but they have not accepted. So this Kawasaki disease is a systemic disease vasculitis associated with multi-organ involvement. So they have several features overlap with this Epstein-Barr viral infection. So rash, sometimes these rash, fever, joint swellings, and all those things they can have in Epstein-Barr viral infections. These red tongue, these strawberry tongue, red lips, sometimes they can have. So most of the time these features both are overlap. So Kawasaki disease is concomitant EBV primary infection is very, very rare. So my child, this child was previously healthy 5-year-old girl, presented with high-grade intermittent fever. In addition to that, she has had myalgia, arthralgia for 7 days. So after admission to my ward, child has had this generalized maculopapular rash with bilateral hand and feet edema. So in addition to that, she has had this bilateral non-pulmonary conjunctivitis and cervical lymphadenopathy, right-sided cervical lymphadenopathy. And strawberry tongues were there. So all the features of this Kawasaki disease were there. So in addition to that, child has had hepatosplenomegaly. The CVS and respiratory system was normal. So due to this hepatosplenomegaly, I want to do this blood picture in this child, in addition to normal investigation. So I thought this is a Kawasaki disease, but with Kawasaki disease, very rarely you can see this hepatosplenomegaly. So that's why I want to do this blood picture. So we did this full blood count. It is a neutrophilic leukocytosis were there, hemoglobin low, and platelet very high. So compatible with this Kawasaki disease. ESR was high, CRP was high. So both are compatible with this Kawasaki disease. ALT-AST also elevated, albumin low, serum sodium low. So all the features were there to diagnose Kawasaki disease. Somehow this one has had this hepatosplenomegaly, so I go to do the blood picture. So I did the blood picture. Blood picture, so this viral with secondary bacterial infection. In addition to that, there was some atypical lymphocytes. So that's the most important thing in this blood picture. So there was some atypical lymphocyte. So then I was thinking about is whether this Kawasaki, very rare these atypical lymphocytes were there. So I want to do these IMA antibody. So in addition to that, I did serum ferritin, SAD, chest X-ray, those both were normal. So then ultrasound, there was mild hepatosplenomegaly, echo was normal, no any aneurysm. LP I did this, there is a high protein with pi lymphocytes. So in Kawasaki people, they can have this meningitis, is aseptic meningitis. So then I did this EBV IgM antibody, that was positive. So then I treated as Kawasaki plus EBA infection. This is a very, very rare condition. So then move to the second case. So rhizomelic chondrodysplasia punctata. So I think most of you have read regarding these conditions. This is a paroxysmal this is a metabolism problem. So rhizomelic chondrodysplasia punctata, very, very, very rare. So I have seen first time in my life. So I had this more problem. So more problems when I was diagnosed this child, because I has had to get opinion from several radiologists, from these Akkarepattu, consultant radiologist Akkarepattu, then Ampara, then Colombo. So I has had to get several opinion from several radiologists. So ultimately I diagnosed this rhizomelic chondrodysplasia punctata. So very, very rare case. So this case I have published in last year in our annual sessions. So these are rare genetic disorder peroxisomal metabolism. So as an X-linked dominant autosomal recessive condition. Here main features are slip calcification around the joint and within the cartilage. So you can see some dots like calcification around the joints and within the cartilage. That's the classical feature of this rhizomelic chondrodysplasia punctata. So they can have several associations. So associated with this spasticity, psychomotor retardation, growth retardation, seizures, feeding problems, recurrent otitis media, and some children can have cervical spine stenosis. And this case is sometimes this prenatal diagnosis is possible. So this is my case. So case of rhizomelic chondrodysplasia punctata in a newborn. So actually this child has a respiratory problem. So died few days after birth. Child was on ventilator, so just after birth. So this one died after few days. So baby girl was born at term to healthy second degree consanguineous parents. As the second child of the family, birth weight was 2.8. Elder brother was normal. Antenatal history was normal. Examination we have found is flat nasal beak with flat face, low set ears, hyperplasia of malaminus, short neck, short chest, very short bilateral arms with long fingers, several joint contractures, and very short bilateral thighs and bovines, post bilateral legs. Otherwise normal. There are several these classical features were there in proximal short thick diaphyses, large and irregular metaphyses, punctuate calcification. There are punctate calcification on these joints, around these joints. So this X-ray you can't see it properly, but there are several dots. This calcification, calcification like dot around these joints. From that features we diagnose this case. Otherwise it will miss. So this rhizomelic chondrodysplasia punctata is very rarely occurring in skeletal dysplasia characterized by slip punctate calcification around the joint and within the cartilage. So this is a very, very rare case. Somehow we diagnose with help of several radiologists in our country. So then I move to this next case. This one also I have published in last year. So Phacomatosis pigmentovascularis. This is a very rare case. So this is a coexistence of vascular and pigmentary birthmarks all over the body. This child, you can see this all over the body. There are multiple these Mongolian spots were there. In addition to they can have port wine stain, melanocytic nevi, and epidermal nevi. Patches of hyperpigmentation or Mongolian spots you can see in this child. In addition to they can have seizures, calcification, intracranial vascular abnormality, hydrocephalus, and deafness and facial paralysis. Ocular glaucoma, melanomas, skeletal scoliosis by spina bifida, and renal ileus. In my child, that child actually presented with developmental delay. So developmental delay with large head. So this one has significant large head with developmental delay. Then I did this scan. There was a hydrocephalus. Then I did the CT also. CT shows this hydrocephalus. So when I examine this child, I have found several Mongolian blue spots. This hydrocephalus. So then I want to get some opinion from these dermatologists. So then I sent to dermatologists, the LRH, this is our Professor Jaminis sir. So then he said there is association between these. So think about these things. So then I have read these all the features were there. So this is my child. So you can see very large head. This child was diagnosed at the DGS Ampara. So you can see the several birthmarks, and these birthmarks were there. Sorry, there. In addition to that, several these Mongolian blue spot. Normally, you can't see these Mongolian blue spot in this area, mainly in these lower limbs and this buttock area. So you can see. So those are the main features. So which will lead to these diagnoses. Okay, this is my case history. So last year, so you can see these all the features here. So then I will move to this neuroblastoma presented with proptosis. This case also I have published in last year. Not last year, this year. So this is neuroblastoma is most common extracranial solid tumor of the infancy. So arising from the neuroblast. Common sites are abdomen, thorax, pelvis, cervical, and other sites. Of course, main common symptoms are abdominal pain, vomiting, weight loss, anorexia, bone pain. Investigation depends on the site. So sometimes you do the chest X-ray, abdominal X-ray, scan, CT or MRI, MIBG scan, bone scan, skeletal survey. So this is my child. So this child actually presented with this red eye with features of some conjunctivitis like this. So before presented to me, this child was brought to this eyes clinic. So seen by some MOs there. So then they have think about these conjunctivitis and they treat with these drugs. Then they went home. Then again presented with so very red eye with some proptosis. So then I want to do further investigations. So there was a proptosis. So we check these lymphadenopathy, hepatosplenomegaly, any renal, these renal enlargement, nothing was there. So then, but this eye redness with this some proptosis is very this unusual. So I want to do some other imaging. So then I did this CT, contrast CT. So contrast CT shows this significant mass, orbital mass in this epidural area or the bilateral frontal lobes. This mass was extended to these frontal lobes, and there was some metastasis. In addition to this bone erosions also there. So then we have done this ultrasound abdomen. So ultrasound abdomen, there was no significant thing. So, but then we send this child to this LRH. So LRH they have done again ultrasound abdomen, show some masses in the renal, suprarenal area. And they have done this biopsy, so this neuroblastoma. And then we have sent the child to the Maharagama and given chemotherapy as well as radiotherapy and all the treatment. So here, most important thing is this neuroblastoma presented with proptosis is very, very rare. So most of the time these proptosis presented, these in children they presented as with proptosis most of the time is due to this retinoblastoma or any other tumor. Neuroblastoma is very, very rare. In addition to here, most important thing is this tumor is erode all over the these areas and these bones also. Then this is the next case, Neurofibrosarcoma of the lumbar spine. So peripheral nerve sheath tumor, this neurofibrosarcoma is the peripheral nerve sheath tumor. So it's a malignant tumor presented with most of the time painless swelling or lump over the affected area. Sometimes pain or soreness from the compressed nerve also muscles. Sometimes they can have nerve loss. In addition to that, if affect these limbs, so they can have a limb or difficulty in rising limb. Most of the time diagnosed with CT or MRI or biopsy, treated with surgery or chemotherapy. So my patient, was this 13-year-old girl. Actually, this child was very well previously. This child has had some pain over the lumbosacral area, left lumbosacral area. So they have come to the OPD, this Ampar hospital, and seen by some MOs and given some analysis and sent home. So after 2 months, this child presented to our unit with right-sided monoplegia. This means these not only right-sided, bilateral, these foot drops were there. Mainly involved is left side. So then we think about what is this cause. There was an obvious palpable lump over this lumbosacral area. So we have done this all the examination, and hard mass were there in the left lumbar region with left-sided foot drops and hypotonia and power 1 to 2 with the diminished knee and ankle and plantar reflexes. And there was a sensory level also, L3, L4. Otherwise, examination was normal. Then we did the CT. CT, there was this suspecting mass. They suspecting about these neurofibrosarcoma. Then this child was transferred to actually LRH again. So they have done the biopsy. Biopsy confirmed the diagnosis. Then this is a very interesting case. This child was transferred from this Bibilo hospital to Ampara when I was at Ampara hospital. See the Rosay-Dorfman disease. What is this Rosay-Dorfman disease? So this is the first time I have seen this child in my life. So I think most of the people have not seen this type of case. So these are Rosay-Dorfman disease is overproduction and accumulation of the histiocytes in the lumbar nodes of lymph nodes of the body. Most often cervical lymphadenopathy was there. These important features of the cervical lymphadenopathy is these lymph nodes are maternal lymph nodes associated with fever, loss of weight, night sweats, mainly affect the children and young adults. So most of the features are compatible with this tuberculosis. So when you get this maternal lymph nodes with fever, loss of weight, night sweats, so you have to think about the tuberculosis. So we also thought about that. And then we have done all the investigation exclude to this TB, all the things were normal. Then we did this biopsy. So in addition to that, this cervical, they can have inguinal, retroperitoneal, mediastinal lymph nodes involvement also. So 40% are extranodal. That means they can have skin involvement, nasal cavity involvement, bone and orbital tissue involvement, and CNS involvement also. And we have to do this children's lymph node biopsy. So lymph node biopsy, you can see these immunomarkers. So we call this S100 immunomarker. It's positive for histiocytes. So treatment method is surgical excision in addition to that we have to give the steroid and sometimes chemotherapy and radiotherapy if there are extensive involvement. So this is a case I was published in our annual session in this year. So this is a very rare case. This is a 5-year-old boy. Person transferred from the Grisel hospital to the Lumbar hospital during that period. So 2-month history of progressive enlarged bilateral neck swellings were there with fever for 3 days. There's a matted lymph nodes were there. So we have done blood investigations. So there is some high, high ESR and high CRP. Then we have given the antibiotic, IV antibiotic, but not settled. So we have excluded this TB and then these persistent matted nodes were there. That's why we have done this biopsy. So biopsy shows these features of Rosset-Dorfman disease. So for this nuclear, this cytoplasmic and other things was these immunomarkers were there, S100 and CD68 positives were there. Then next case, cardiomyopathy with congenital cytomegalovirus infection. So this case also very interesting case. In cytomegalovirus infection, the most common congenital viral infection is cytomegaloviral infection. They can cause IUGR, prematurity, microcephaly, jaundice, and fatigue. In addition to that, they can have hepatosplenomegaly, periventricular calcification, chorioretinitis, pneumonitis, hepatitis, sensory neural deafness. In addition to that, there are several other minor features there, but main features are these features. So how do you diagnose? We have to diagnose with viral cultures, but not available in Sri Lanka. So mainly we are doing PCR. So in addition to that, we have to do the CT brain to see these calcifications, periventricular calcification. We can see in eyes. We have to do the eye referral to see the chorioretinitis and hearing assessment for sensory neural deafness they can have. So main method of treatment is IV ganciclovir, oral valganciclovir. This is a case I have published in this year. So child with dilated cardiomyopathy. This child was actually this case is very interesting case. So when this child aged around 5 months, so this at birth this child has had this ear tag. So then we want to do this ultrasound abdomen to exclude this renal anomaly. So then we send this child to radiology department to do this ultrasound. So somehow they have given around 2 or 3 months later date. So they have done ultrasound abdomen. So during this ultrasound abdomen, this radiologist found there is some enlarged heart. So then this radiologist called me and sent to me this child. So then I check this child. There is this not significant murmur, but I have taken this X-ray. So X-ray there was a very large heart. There was a significant cardiomegaly. So then I discussed with cardiologists, this Sirma Bandaranaike hospital. Then I sent there. So they have done these 2D echo and diagnosed dilated cardiomyopathy. So then they have sent again to me and asked to do this basic investigation to exclude this cardiomyopathy, because to found out this cause for this cardiomyopathy. So I have done all the investigations. These blood gases, CPK levels, and these liver function tests, and all the things I have done. So including this torch screen. So then this child we sent home with some drugs, and after 2 months, so these reports were not there. So after 2 months, this child presented with severe respiratory tract infection. So during that child, there was a significant heart failure. So we discussed with this cardiologist, but unfortunately, child died. after few days. So just with the just before death, so we got this report from this MRI after 6 weeks or 2 months, I think, with this positive IgM antibody in these blood report. So somehow after trace these report, we have done this basic investigation to see for other causes of other features of this congenital cytomegalovirus infection, such as CT brain and these eye referral. Those things were normal. No ultrasound abdomen also we have done. There is no hepatosplenomegaly, and CT there were no calcifications, and eye there were no problem. So only problem here was this dilated cardiomyopathy with congenital cytomegalovirus infections. So we have excluded other causes such as hypothyroidism, hyperparathyroidism, thalassemia. So to features see this is glycogen storage disease. All the features all the investigation we have done, those things were normal. Then next case. So this case was a very interesting case. So calcified posterior mediastinum neurogenic tumor. So neurogenic tumors are most of the time neuroblastoma or ganglioneuroma or neuroectodermal tumors or paraganglioma. So most of these mediastinal, this type of neurogenic tumor located in this posterior mediastinum. That's the most important feature. Just be associated with this vertebral column. So then these patients they can present it with this local pain, dyspnea, dysphagia, hoarseness, and in addition to that, they can have several other features according to the place of this posterior mediastinal tumor. So diagnose with this chest X-ray. You have to do the X-ray, PA view as well as lateral X-ray to locate this what part of this mediastinum, whether it is anterior mediastinum or middle or posterior mediastinum. In addition to that, you can do the chest X-ray, MRI chest, CT chest, and final diagnosis with this transthoracic needle biopsy. So treatment wise, we have to do the video assisted thoracoscopic surgery or open thoracotomy and do the surgery. So my child, so 18-month-old baby girl, this child was transferred from this peripheral hospital because this child was treated there for 5 days with IV homocysteine, and there was no significant improvement. So they sent here to this base hospital, this Professor Senar Bibile Memorial Hospital, Bibile. So they transfer here. Then when child admitted here, child was very well. Only very few lung signs were there. No other significant features. So they have given antibiotic for 5 days. So she planned to discharge, but I has had some doubt why they have transferred here without any significant lung signs here. So then I want to do somehow chest X-ray, because this one transfer from this peripheral hospital after giving antibiotic. So at least we have to do some basic investigation here, because these peripheral hospital they don't have these chest X-ray facilities and other investigation facilities. So before discharge, I want to do the chest X-ray to see whether there is any problem. So then I did the X-ray. So you can see in this X-ray there was discharge X-ray there was some calcification in this posterior. This just associated with the vertebral column. There was some small calcification. So I thought this is very unlikely. Due to this some foreign body is unlikely. So these linear, these vertical calcifications were there. So then I discussed with this radiologist. Radiologist asked to get this lateral view. So I did the lateral view. Lateral view obviously show that this calcification just in front of this vertebral column. So then we discuss both of other discuss regarding this case, and the radiologists say that we have to do the CT. We can't do CT for this child here. So then we discuss with these radiologists, these pediatric radiologists at Cinema Bandanayak Hospital, and then we send there. So finally, we have done the CT. So ultimately, there is this neurogenic tumor. They suspected neuroblastoma. So then I discussed with pediatric surgeon at Cinema Bandanayak, and they have transferred to there, and they have done there these thoracoscopic needle biopsy, and which show this neurogenic tumor in this posterior mediastinum. This is a very, very rare case. And then they have done these thoracotomy, open thoracotomy surgery, and remove this all the part. Then this is the last case. This is autosomal dominant congenital nystagmus syndrome. So you know this, what is the nystagmus? Nystagmus is conjugated horizontal oscillation of the eyes. So in this syndrome, in addition to this nystagmus, they can have visual acuity problem, strabismus, astigmatism, and occasionally they can have head nodding. This is autosomal dominant. So several family members are affected, and most of the time this congenital nystagmus syndrome, they can have learning difficulties. So this is my case. This is actually 7-year-old girl admitted to my ward here, this Professor Grisel Memorial Hospital, with some abnormal eye movement. So then I check this child. There is obvious nystagmus, so horizontal nystagmus. Then I asked regarding the child's learning ability. Mother says she don't have this good learning ability. So then I asked regarding this family member. So mother says his elder sister also has same features. Mother's brother has same features. Mother's brother's daughter has same features. Mother's sister's son has same features, and grandmother also has same features. So nearly 6 or 7 family members are affected in each generation in this case. So all of these affected people has had this learning disability, so learning problems, and all of them have these visual problems. So very interesting case. Then I have done the CT because the child has nystagmus, so CT was normal. Then eye referral done. Eye referral, there was some visual problems as to where this is spectacles. Then I got these. I have done another investigation to exclude these other problems such as thyroid profile, ESR, and other things. So those all the things were normal. Then I got opinion from these our pediatric neurologist, Madam Piara, from this LRH. So Madam also diagnosed this my diagnosis. So Madam also said this is autosomal dominant congenital nystagmus syndrome. So this is a final case. So I think I have done some interesting cases. So with this, most important thing is I have diagnosed all the cases when I was working at peripheral unit. So anywhere if you are treating, if you are doing this your work, no problem at all. If you have interest, you can diagnose any type of case. So I would like to thank these all staff members of pediatric unit at BSc Malanduwa, BH Chakrapattu, DGH Champara, and now at Professor Senak Bibile Memorial Hospital, Bibile. So, and especially this support from these neurologist, cardiologist, and endocrinologist, dermatologist. So several people support me to diagnose these cases. And take home message. What is the take home message here? This take home message is, if you have interest, you can diagnose any type of case in anywhere in the country. So most important thing, you should have some interest regarding these cases. If you get a child with some abnormality, you have to always think this child has some problem. Okay, thank you very much.